All right. Obviously, when we talk about failures, I will always talk about those of the companies I worked before. I mean, never at FHI 360, of course. Yeah. Okay. All right. Yeah. But I always like it's a nice icebreaker. We should talk about this more. The World Bank once did these failure parties, which I found were excellent because I learned a lot from these sessions there. So I think we can start. We have, yeah, 2 or 3 more people trickling in. Excellent. So this session is about reducing the digital divide. Well, we will talk about it. We're not going to reduce it here in the session, but we give it a try. Yeah. So this is how to ensure an enabling environment for equity tech for all. And we heard about this already a little bit in the plenary earlier on. And actually, we had Osama. Well, you were in the panel earlier on as well, and you were talking about digital exclusion. So we are talking a little bit about this more. And so I will just quickly start with the intro. I'm Daniel Messer. I'm the CDXO, the Chief Digital Officer and IT Transformation Officer at FHI 360. I will just set the scene a little bit here. I myself, I worked before at, since 25 years in this area. I used to work at IPPF and then at PSI and now at FHI 360. Just to give you a little bit of an idea, my first computer was a Commodore C64. I don't know if anyone can beat that. Yeah, you had it. Yeah, you had a Sinclair ZX81 or? Oh wow. Okay. So, but yeah, so I'm in this area for some time and have always been very, very passionate about digital health when we sort of built our first applications and moved in towards that you can actually go into some, what you can do with mobile phones and so forth. So so it was passion my whole life about it, but I actually have a sociology background. I don't know how I really ended up in technology. And I was thinking back what I could do today with the digital footprint, what you sort of collect as metadata around your mobile data collection, or just the digital footprint around normal usage of a phone. It would have been a dream at the time for sociologists to get that kind of data. And now you just get it as an add-on. It's just a food for thought that I'm always thinking. For the session here today, we saw amazing new technologies yesterday, from like an add-on for your phone to sort of get a dental diagnostics, or the what you could see like the diagnostics, the typical stethoscope and stuff like that, or even that pill with the camera, so that will replace the dreaded colonoscopies, and that you can now apparently already buy at Amazon. That is real. I actually saw this a few weeks ago. My father-in-law was hospitalized he lives in Paris, and they just couldn't find out what it is. He was bleeding and so forth, and they put this camera through him. They found what it is, and they fixed it. That's in Paris. France is always voted as one of the best healthcare systems in the world. So what we are talking about is not Paris. We are talking about very different environments in low middle income countries. And I just want to set the scene for what we mean with digital divide. We might have some sort of cell phone penetration. We might have some smartphones around there, but getting towards these kind of digital tools, this might not be available everywhere. And I was always thinking, talking about another failure from previous life. We had this iris readers to get back in PSI in a project in Madagascar, and it was brilliant. So because it's really unique to the person you read the iris from, and that will give a unique identifier, and then the person comes back to the clinic. It can easily re-identify the person, which was great until the machine broke down because no one in Madagascar could actually repair it because it wasn't produced there. So I'm just setting a little bit like the challenges you might have with these kind of amazing technologies. So one term we sort of, right, like when we talk about equity and a technical equity, tequity was a term that I heard yesterday that I really liked, which is like probably very, very spot on for what we want to talk about. But we also heard about yesterday in the keynote about that leapfrogging opportunity, and I think that is also something I'm really excited about when we think about that years back, the banking sector in Kenya. We could all of a sudden we might not have the banking sector established in other countries. We might not have landlines in land, but we had cell phones, and we could then easily bridge that, and all of a sudden we had Kenya started the mobile banking, years before actually. I mean, we still do paper checks in the United States, and they did this in 2007. The same, I think, we saw during COVID, where all of a sudden said, whoa, we can't access our community healthcare workers, we can't access the clients directly, but everyone has a cell phone and has maybe WhatsApp or whatever running there, and we can bridge that gap all of a sudden. So there's an opportunity to leapfrog here, because when we sort of look in low middle income countries, when we all of a sudden can do diagnostics now, things using cell phone or mobile technology, where we just said, well, you can't replace a doctor. Well, there is no doctor where we are sort of operating there. So we have a more challenging environment. Here is the chance to leapfrog. But do we leapfrog for all, or is it just a leapfrog for some who are actually privileged? And that is sort of this kind of digital exclusion that we were talking about earlier on. And this is something we want to discuss in the panel today. There is, you saw an introduction also, we want to mention what AI means for this digital opportunity, but as well as exclusion. You might have heard, like, when some of these AI models are being tested sort of on investor setups, and then all of a sudden they might not work for the languages you're operating in. Phil, he gave a good example of that yesterday. So these are challenges where we have to think about equity in the countries we are operating in. So with that said, I would like to introduce my panelists. We have an amazing panel today. So we have Rose Delia Gasiko, a data science community manager from Sydney, South Africa. And yeah, if you could, it's just here. And I will tell more about each of the panelists before they sort of start with their presentations today. And then we have Osama Manzar, the founder and director of Digital Empowerment Foundation in India. We have Debbie Rogers, the CEO of Reach Digital Health South Africa. And we have Edward Budi from CEO Reach Singapore. Sorry, Reach 52 Singapore. Because we have two Reach here, so it's a popular term. Yeah. So we will do like individual presentations first. They will not be very long, just 10 minutes. And after that, we will have a little fireside chat. We will have some questions for the panelists, and after that, we open the floor for you to ask questions to the panelists as well. There's a lot of very, very rich experience in this panel, so I would encourage everyone to take that opportunity. So if I start with you, Rose, and before I ask you to just say a few words, like you're passionate about equity in technology, working tirelessly to bridge the gaps in access, opportunity, and representation across Africa. As a data community manager at Cindy, Rose leads a diverse network of over 250 ambassadors in 30 countries, empowering underrepresented communities to access knowledge, build skills, and leverage the transformative potential of AI. Through her leadership, Cindy has become a platform that not only drives local solutions, but also ensures inclusivity for all. As a community chair for deep learning in Daba, Rose champions equitable access to AI resources and collaboration opportunities. She brings together AI communities across the continent, ensuring diverse voices are heard and celebrated in shaping the future of AI in Africa. Her role in UNESCO Women for Ethical AI Expert Network furthers her commitment to fostering ethical, inclusive AI practices globally with focus on uplifting marginalized voices. So Rose, if you could come here and maybe tell us a little bit more. The clicker is, you click here and here you are.
Awesome. Okay, so thank you so much for joining this session, and I hope you get to learn a lot about equity because it's a topic that's really close to our heart even as Africans. And I'm going to talk to you about how Zindi is bridging the digital divide and enabling an environment for equitable tech. So I know throughout this conference we have heard about Africa, and we always see this map either in a different color or a different shape, but it always communicates the same thing. We are very underrepresented, and this is due to lack of skills, lack of data, and lack of compute, and very many more, which I'm going to continue talking about. So as we continue to advocate for equity, I want to share why it matters to us, especially as Africans, given we are very culturally diverse. We talk different languages. I can also mention I have my Kenyan friends representing, and we are all from different tribes. So we need to develop solutions that will be able to cater for the different cultural and diversity that we have. And also, inspiring global collaboration in the aspect that as Africa, we also are looking at developed countries to be able to give us maybe the support that we need, even including the compute. And we don't want to only be the recipients of this kind of aid, but also the contributors. So this is very important to enable the equity and also tackling the bias in global health, because as you know, maybe data sets that are being trained on global health data are not representative of African data, and it can bring about algorithmic systemic bias. So we are advocating for equity to bridge this gap, and also combating health disparities, where you get to see most of our institutions or our healthcare are they're not well funded. We have a lot of challenges in the aspect that even our nurses, I think when I left Kenya, they were still striking because they're not given enough money to just continue taking care of the sick people in the community. So we experience a lot of brain drain. So these are some challenges that you see that bring the digital divide. And I want to give us maybe a quote. Inclusion is not just an ethical obligation, but essential for creating effective, accurate, and impactful tech solutions. So that's something we need to keep in mind even as we develop the AI solutions that we are working on. And just to run through the challenges we experience as an organization advocating for equity. One, we lack access and we have expensive internet. Even sometimes to join a local Zoom call, it already costs us a challenge. You keep dropping off. So you can imagine developing AI solutions, how it looks like, and even infrastructure. Also, lack of available data in our healthcare systems. Either the data is still manually input in some institutions, or the data that's available publicly is very outdated. And also the quality, sometimes you find the data is not complete, you can't even develop a solution on it. So that's a challenge that we experience. And we can say we are pushing really hard to have skill availability. We have hubs in Kenya that are advocating for digital inclusivity and all that, but then the opportunities also brings this disparity and this divide, because you find either institutions don't understand what AI is, or they do understand, but it's not in the aspect of developing this AI solution. So those skills that will impact our youth go unrecognized, or again contribute to brain drain. So this continuously brings a digital divide. And also exclusion from maybe global AI ecosystem, like funding. Sometimes you see the funding that's given in Western to contribute to the AI ecosystem is much more compared to Africa, which is not enough to build a sustainable AI solution. So that's a challenge. But I also want to appreciate that PMAC was able to bring us here to air out the challenges that we are facing, like inclusivity in conferences. So that's amazing. And I included conference here because I think 2 years ago we were celebrating representation at a conference where an African research paper was, the first African research paper was shown in like forever. It was just the first time that an African research paper was accepted at ICLR, and we were celebrating Tunisia for that achievement. So this is something we need to keep working towards so that we bridge the divide. And also lack of proper ethical AI policies and regulations. Our leaders sometimes don't involve the community. I think this some time back, as we were fighting against the financial bill, we were also fighting against a robotic bill that was not incorporated the views of the people who are working with AI in Kenya. So this type of policies either introduce bias or continuously bring on a divide because it's not inclusive of our environment. And also there's lack of cultural integration, as I mentioned, and community involvement. So again, we are very diverse and we are very community-centered as Africans, and lack of this won't, like, AI is just a tool. We need something that's going to be able to impact even the woman who's selling groceries in the rural area. She needs to understand what this system is and how it's going to benefit her. And also limited collaboration between our governments and our private sectors is also a challenge. So now I'm going to walk us through quickly on what Zindi does to bridge this gap, and I'll take you through what Zindi is. So Zindi builds AI together with the community. We have over 70,000 data scientists on our platform, and we have African data sets onboarded on our platform where we crowdsource solutions from our data scientists, and we were able to give those solutions to the various African countries that the data was collected from. So when you join Zindi, you'll be able to see we have data sets from climate to healthcare, etc. And one of the things that we are trying to do to bridge this gap is data set accessibility. People say we don't have enough data. We are trying to bridge that gap. And right now we are doing a challenge on malaria detection. I know from the Right Foundation, they're also doing something similar in Cape Town, and now we are doing something similar in Uganda, given the Ugandan context, and we have people contributing towards that from Uganda to build a solution from them. And also, right now, we're also working with the government of Malawi in the healthcare workers of Malawi to build a LLM system that will be embedded in a chatbot for public health systems in order for them to be able to support their communities better and give them services better. We also are working on bridging the gap of talent and having localized solutions, as I mentioned. So the data sets we have, our community, we work together and crowdsource solutions, and they're able to be displaced in the different countries that require those solutions, and they are used. We also push for collaboration, because as I mentioned, we have a challenge of either data, compute, and the likes of big tech that are currently placed in different parts of Africa, like Meta, AWS, Google, and Microsoft Databricks, are able to be supportive in this nature because we advocate for the collaboration because of the things we don't have. And also with the community like Deep Learning Indaba and Masakane, enable us to reach the underrepresented communities in the different parts of Africa to either, once we build the AI solutions, we're able to translate them into local languages for our community. We also enhance digital literacy, whereby we collaborate with IBM on Skills Build to offer professional skills, job application skills, artificial intelligence skills, data skills to our community so that they can be able to understand the importance of this emerging technology. And this we see is a big difference because we see our communities now building the solutions and it's coming towards equity and bridging the gap. And we'd love to see public health data. So if in public health content. So in case it's something you're interested in, I would love us to talk and collaborate, which is one of my next steps on collaborating and exposure. I know we can learn from each other, so it's definitely something we're looking forward to. Investing in data infrastructure and developing AI, again, it's still a challenge for us. But as we can see, with the likes of DeepSeek, I've seen many Africans are commenting and they're very excited that maybe there's some hope that we can even use some we can be able to navigate through this type of technology because we are seeing some examples that are coming up that we can use less and expensive data or platforms or in infrastructure to develop our AI solutions. And also enabling data access for all. That's something we are always forward about because we want more inclusive African data sets to be building the AI solutions for us. And again, promoting community development programs just to equip our community to understand what AI is. And one last example I would give is the amazing work we did in Nigeria, where 100 people came in a church to learn about responsible AI. So that was one amazing thing we got to see that our community was able to participate in. Yeah, let's collaborate, and you can scan to learn more about Zindi and connect with me. Thank you.
Thank you, Rose, and incredible, exactly 10 minutes. So, but that timer is intimidating. We have this timer here, so. I would like to ask Osama next, maybe to come to the stage and present. Osama is the executive director and founder of the Digital Empowerment Foundation in India. In his capacity, he works in the intersection of rights and meaningful access. Osama has served as a senior Ashoka Fellow, a British Chevening Scholar, and an International Visitors Leadership Program Fellow of the US State Department, and an advisor for Women in Digital Economy Fund. After half a decade of stint in tech journalism, he founded Digital Empowerment Foundation in 2002, working on access rights and rights to access. His organization ended up digitally empowering more than 35 million people to date, so even more probably by now, and through the establishment of more than 2,000 digital centers run by infopreneurs and Suchnapreneurs. Again, you have to explain what that is. But Osama has been on the board of numerous organizations, including Women in Digital Economy Fund, the World Summit Awards, and been profiled by The Hindu as the man who traveled more than 10,000 villages. So you really got your steps in. So,
yeah, thank you. So I want to say that I come from a country where we do digital literacy without the use of digital. We have to, because otherwise it's very difficult, because everybody doesn't have digital, but they end up using some way or the other. So, and we teach how to get connected to the unconnected people. So we are also now teaching how to use AI without being AIized, you know, or they are being AIs, but they don't know, you know, something like I mean, most of the people use Google Map, but they don't know that's an AI, right? Because they use your data and then push the, you know, result to you. And therefore, you know, when they are going to a hospital or going to any office and there is a CCTV camera, then you don't know how that is going to be used, and so on and so forth. So there is a very challenging situation in a country like us. And I also feel that why we don't have person like her and the situation like her, where you have a community-based data literacy in charge, the meaning of data, the meaning of how do you give information, and so on and so forth. So I was just thinking that we used to have digital entrepreneurs, which is Suchnapreneur. Suchna is information. Suchna in Hindi is information. Preneur is entrepreneur. So we have this cadre of women who are information entrepreneurs, but now they have to be upgraded to the level of not only providing information, but also perhaps telling them how their information is being taken and they are going to be used. That's where the AI comes in between. So I'm very bad at using slide, but not so bad in speaking. Because there was a structure and all that. So we are we are a country where 48% of the population out of 1.4 billion and is not connected. But that 48% is larger than several countries, and those 52 who are connected are also larger than several countries together, right? So our data says that we are 1 billion plus data SIM sold country, right? But the fact is, are they all really connected? Are they meaningfully connected? Are they consciously connected? Are they all able to pay online? Are they all able to fill a form online? Because that is what digitization means, or digital usage means. Just talking to your relative in Washington, D.C., whose son has gone from there 70 years back and is not really digital literacy, talking to them. That's convenience of use of digital and digital. So those are the situation that we are into. So we are actually, as an organization, we are in too much of questions rather than solutions, to be very frank. And when this topic came to make a presentation, this is how we thought that maybe we can discuss with you. And we are in a position of, we cannot give an AI solution to masses or to the government, but we are in a position where we can ask questions, why this solution is not good, why this solution is not inclusive. And that's what we have been doing. As you can already see that what is our digital landscape? It's half empty and half full, and in that situation, how do you really put in? Because government and the corporates are pushing AI policies in every provinces. AI policy. We don't even have a mobile to use and you are pushing AI policy, which also means that you are collecting data of all of us as an entity without us being digital tool in our hand, right? So we are being data-fied, but we may not be data users or a data-informed users. And that's a very, very serious questions that, because AI doesn't work without data. And I'm not using data, by the way, because I don't have mobile, I don't have digital. At the most, I go to a public access point to withdraw some money through, my mobile wallet or something like that. But that's it. And but I keep getting calls or my family members and they say that, can you provide your OTP number? I'm transferring some money, and rather than transferring, they will take all the money from my bank, which is actually not a technological problem. It's a behavioral issue. It's a social and behavioral issue. How do you do the literacy? When we say digital literacy, actually we have to do the social behavioral literacy in a digital environment. How do you use that one? So, the Indian context is very, very paradoxical, I would say. I mean, for example, we have 2.4 million, if you look at the second part of the slide. We did AI literacy. We had a project that we got funding for, and we did an AI literacy. People don't even know how to use mobile, and you're saying, what is AI literacy? How do you create a curriculum for doing AI literacy? How do you do that? And it was very, very, of course, 72%. I would say that this data may be much more positive. More than 80-90% would not be knowing AI at all. But many of the people have been asked the questions that, do you use this app? Do you use this app? That means you should be knowing AI, and so on and so forth. So we created, there is a case in example that we are a very grassroots-based organization, but we had to create a just AI division in our own organization. And the job of our that division is now doing deep research of finding out that how it will benefit the communities and the people at the grassroots level. Because most of the people are also working in the AI ecosystem at a very corporate level, at a middle layer, at the top-down level. But what about the people whom you are promising to serve? Let's say from the community health centers, or let's say public health centers, or something like that. So is there a proper research being done or not? So that's what we have been doing. And we are also working with various kind of government in various state level, because we are 36, 38, 35 or 36 states. And every state is working on AI policy. And in the earlier discussion, I told you, when you are working in your own state, not all states have a good example or a bad example. Some states have extremely worse example. Like the example that I gave. I mean, there was another example that people were deleted for being, even alive. And then in another examples, people are being fluked. And in other example, and this is a live example with my discussion with one of the state's bureaucrat, is that they created an algorithm using all the data of the previously collected database, maybe from the driving license, maybe from transportation, maybe from other, and they wanted to come out with a result to serve maximum number of people. And their algorithm was 15% less precise. And they ended up creating a database and deleting, few 100,000 people for serving. And because they were not part of the database, because they used the database which was not really giving a good algorithm. And then they decided, no, we are not going to use this one. We are not 99% accurate. So in a country like India, your algorithm is not 100% accurate, can delete several million people from your database to serve. And when you talk about health services is very preventive. The other day also I was sharing, health information based service is preventive medicine. Preventive health is 85% of the health service. How can you serve with a knowledge and information without collecting complete data about the people, about the health issues? And ethics come in between. And that is where the biggest issue at the moment going on across our country is that how do we make sure that what people who are digitally excluded should not be data excluded. People who, and they are not consent excluded. That's very, very important. Otherwise, what is happening is that in the name of digital inclusion, till the time you are not included, you are actually excluded. That's and that's actually I want to also put into that one, is that there is a example in our country, is that everybody has to authenticate with a biometric thumb to get your ration. It's as simple as that. They have digitized the whole database, and it has to be linked with the national identity card. Right? Now, if the database with your thumb impression is not matching with my Aadhaar, which has a name called Osama Manzar, but written with a spelling mistake like Osam Manzar, then you are deleted. You are excluded. And that's very, very important, that what kind of database we are creating. I will end there. But what I'm saying is that we have more and more and more and millions of questions, that how are we going to build our data sets, how what ethics we are applying, how we are going to create that environment with the community included, which is actually not data literate, but you are making all your decision based on the data. What kind of policy that should be made? Thank you.
Osama, thank you so much. So your last example did remind me of a friend of mine who when he registered for the Social Security card when he was like probably a boy in the United States, they got the name a little bit wrong. And he tried to change that, and someone told him, look, it's actually easier if you change your name than changing that one, which I found incredible. And they were dead serious. So thank you. So next in our panel is Debbie Rogers. She is a dynamic leader passionate about advancing mobile technology for health. She brings a wealth of experience and expertise in her role as CEO of Reach Digital Health and a board member of Turn.io. Her leadership tenure at Reach, spanning over a decade, has demonstrated her ability to drive innovation, deliver impactful solutions, grow the organization, and expand its program to new African territories. She's also passionate and dedicated to promoting diversity and inclusion in the technology sector, particularly in Africa. Debbie, all yours.
Thank you. So a little bit about the sub-Saharan African context. I am from South Africa, but I work across the sub-Saharan region. So we have 14% of the world's population, but 25% of the global burden of disease, and only 3% of the health workers. So this is obviously a situation that needs drastic intervention, and we can't keep doing the same things over and over again and hoping for a new result. And this is why Reach Digital Health exists. We want to be able to change this view, or at least address more of the burden of disease within sub-Saharan Africa. So despite the challenges that people face from a health perspective, there's also a lot of opportunity. We have a very youthful population across Africa, and we all know that the youth are particularly digitally literate. There are 400 million smartphone connections across the continent, and 70% of people across the continent have access to a mobile phone. Not only that, but you'll see that things like WhatsApp are almost ubiquitous in their usage across different key markets. So we really harness this opportunity looking at the challenges faced by the continent, and we bridge the gap in healthcare using mobile technology. So we use very, very simple mobile technology, things like SMS and WhatsApp, no apps, nothing to download, just what you use to communicate to your family and friends every day. And we use that to communicate directly to citizens about their health, helping them to improve their health both through self-care and through access to the right care at the right time. We also recognize that once somebody accesses services, they're going to be encountering a healthcare worker who is likely demotivated, under-supported, under-resourced. And so we use the same technology to communicate directly to healthcare workers to help improve their health, their mental and physical health, and their resilience, as well as their clinical knowledge, so that they can offer a better quality of care. So when you have millions of people that you're reaching, citizens, not patients, because you don't have to be ill to access healthcare, but when you've got millions of citizens and hundreds of thousands of health workers, there's also this amazing opportunity to be able to gather information from them that can be used in real time by the health system to change the health system for the better. So for example, if you understand what the antenatal care is across the country for mothers, you can target interventions of training, or perhaps you know that there is a need for supply of certain stock. These sorts of things can come directly from the citizens and healthcare workers. So that's a little bit about what we do. I really think that, much like what we saw with the challenges from a healthcare perspective in Africa, there's also the opportunity of mobile technology. I think that opportunities for impact and possibilities of increasing inequality are really two sides of the same coin. It's very difficult to talk about this is what is going to create an unequal society, or this is what is going to create an equal society, and trying to separate those two, because very often they are really the same thing. And so I'm going to just talk through a couple of examples of both opportunities but also potential for increasing inequality. So not surprisingly, I'll do the obvious one first, since we do a lot of direct-to-citizen communication. Direct-to-citizen communication has grown massively over the last 5 years. I won't tell you how long I've been in the space, but definitely before COVID, there was generally a feeling that educating citizens about their health was pointless. And that there really wasn't time or energy to invest in this. I think it was an arrogance. I think it was also a feeling that those poor people over there don't need to be informed because we'll tell them what to do. And COVID-19 hit, and suddenly nobody knew what was going on, even the most educated, even those in the West. And so there was an immediate uptake of really, at a really large scale, of communication directly to citizens. Example here is that within a few weeks of the pandemic breaking out in South Africa, we launched a COVID-19 WhatsApp and USSD service in South Africa. And we reached 5 million people, within the first month. We also launched a program with the World Health Organization a couple of weeks later, and we reached overall 46 million people in 200 countries and territories with communication around COVID-19. So there was just this massive groundswell of people wanting information and recognizing how important it is that they are educated about their health. And so this is offering amazing opportunities. However, it also stands to be able to increase inequality. Why is that? Well, what about the 30% of sub-Saharan Africans who do not have access to a mobile phone? That leaves them behind. And so now we're sitting with a situation where, yes, sure, you have increased knowledge and behavior change in a subset, but not across everybody. Does that mean that we leave behind the 30%? Well, the way that I think about this is that you have to work within a system, and you have to work within the government system, and you have to think about how your work works within the system. You cannot do it just simply on the side, because you will definitely then be increasing inequality. We work with government so that we can help to reduce some of the burden on the healthcare system, but so that we can also target interventions to those who don't have access. These are non-digital interventions like community health promoters, for example, who now can focus their energy on those who don't have digital access, rather than having to talk to everybody and hope that they're reaching everybody. So I think it's very important to understand that this is a systemic problem, and therefore you need to operate within that system, and you need to understand what your role within it is and how you might increase inequalities. I feel very weird putting this slide up because Patty is in in the audience, but I wanted to talk a little bit about an enabling environment. So this is the Global Digital Health Monitor, and this was an initiative by Health Enabled and the World Health Organization, and this looks at whether or not there is an enabling environment for digital health in various countries. Now, you'll see obviously a stark difference in sub-Saharan Africa compared to the rest of the globe. But let me tell you, since we initially started looking at these things, there's been massive improvement across the continent. And we're definitely seeing a much more enabling environment, particularly in things like standards and interoperability, investment, legislation. These things have really really moved a lot over the last couple of years. But one area that I think we need to just really focus on is workforce. You can see that this is one of the biggest challenges across the globe, and I can tell you now that this is one of the big things that's affecting most sub-Saharan African countries. So by workforce, I don't mean tech workers who are developing applications. I mean the health workers and the community health workers and nurses and physicians who are digitally literate and are able to use digital health. And there is a massive dearth in this, and we have to address this through education. I think Osama has already spoken a lot about those disparities, so I won't take much more time on it. But I do think it's very important to understand that that still lags behind everything else in terms of how we're doing for an enabling environment for digital health. And then we've got the intersection of climate and health. So I happen to think that there is an immense opportunity for digital health in terms of addressing the adverse effects of climate change. So for example, in South Africa, we have a maternal and child health program, and extreme heat is affecting pregnancy outcomes. It has adverse impact on things like preeclampsia, stillbirth. And so what we've got is a situation where where we're being affected by climate change, even if we're not necessarily contributing as much to climate change. And so we're able to target messaging to people in certain areas to tell them when there's going to be a heat wave, to help them to care for themselves so that they don't suffer adverse effects from climate change. So that's a wonderful opportunity for us to be able to reach out directly to citizens. But Africa is disproportionately affected by climate change. So by 2030, it's estimated that 111 million extremely poor people will be exposed to droughts, floods, and extreme heat in Africa. And this is not going to be solved through digital health. In fact, one of the challenges is that we're using AI is going to accelerate usage, which is a big problem that we need to look at. So I'm done on time. I think also Rose covered most of what the challenges are when it comes to AI, and particularly generative AI. But I will just say that I'm very excited about the opportunity of AI. But for all the reasons that Rose mentioned, we have to be extremely careful that this isn't the new way that we're going to be creating more disparities in digital health. Thank you.
Debbie, thank you so much. I think in one of the early breakout sessions, we were talking about pilotitis, and we saw that in digital tools, and we might see this in AI. I remember COVID was actually when we met the first time, and Reach actually had the tool that could really reach. So the scale was impressive. Also, you mentioned the digital atlas. So if you want to know more about it, Patty Michaels is here, so talk to her. So the next panelist we have is Edward Booty, and he is the founder and CEO of Reach 52. It's a tech startup on a mission to connect 52% of the world that lack access to essential health services. He and Reach 52 focus on distribution of essential medicines with integrated health promotion campaigns. Driven by tech and data, they work across Asia and more recently in Africa, focusing on rural and underserved regions. Ed, it's all yours.
Good morning, everybody. Good morning. Still awake? Thank you for staying for the fourth presentation and the fourth or fifth day, depending on how long you've been here. So yeah, as mentioned, I'm Ed, based in Singapore from the UK. Set up Reach 52 now 7 years ago, which is staggering. Rough intro to our model, just is we're collecting data. So we work with people in communities to collect data first on their own health needs. So health gaps, medicine pricing, that kind of stuff. And then based on that, we do two main things. One is we do health education events and screening, which is based on that community needs. And two is we look to source and distribute essential medicine that's missing in that community or too expensive. So yeah, data collection first, and then education and screening, medicines that are relevant. Yeah, started in Asia, but as mentioned, more recently, Eastern and Southern Africa too. Rolling forward, where does our name come from? Over 52% of the world, now 4.5 billion people, according to WHO and World Bank, cannot access essential healthcare. So it's actually now 56% of the world. Since I set up the company, it's gone up, 4%. When we looked at that problem, about 90% of medicine spending is out of pocket, significant driver of out of pocket costs, and often medicines are 20 to 30 times more expensive in, poorer regions than cities or indeed richer countries like Singapore or the UK. What we're doing, we have a tech platform. Firstly, we look to collect data. I'll make this slide build. So data collection across rural communities. We then have Reach 52 Access, which distributes essential medicines, sourcing from large pharmaceuticals. And we have our own brand of generics too. And then integrated with that, say we're launching a diabetes medicines, we use the profit from the medicine sales to fund diabetes screening. So we're understanding the needs, We launch the medicines either from, sourcing from Pfizer or Novartis or somebody like this, family planning products, whatever it might be, and our own product. Margins drive health education and screening. How it works, already mentioned this. We train people from communities, generally women, to collect data from pharmacies, households, understand their health needs. Based on those health needs, Reach 52 Impact runs health education campaigns. That can be group events, that can be one-on-one, and so on. And yeah, integrated to that, Reach 52 Access would work with local pharmacies, local clinics. We have networks of local distributors. We sell and we distribute essential medicines. First part of this presentation is explaining what we do. Second half, I'm going to drill into some of this data, outcomes, what happened to health when you sort of join the data and these two sort of business units together. As mentioned, based in Singapore. First country was the Philippines and Indonesia, but now we're pretty much nationwide in India, 300 full-time staff. We work with 400 distributors. We promote 52 medicines, 52 products, coincidentally, not by design, just what we got to last year. Through the profits on that medicine, we run about 100,000 screening events a year, 8,000 a month. We screen about 500,000 people a month for different diseases. That's entirely self-financed, no grant money. We've trained about 38,000 health workers over the past 2 years. 14,000 was last year alone. So yeah, we sell and distribute medicines. About 70,000 pharmacies and clinics buy from us. Exclusively rural. We're sort of talking tier 4, tier 5, tier 6 cities and towns, or towns. And then yeah, margins from that drive health education and screening. Back end of last year, we started looking at East Africa. We have a pharmaceutical manufacturing license. We've got about 8 major pharma product companies that will distribute products to us. We've signed 2 of them. We're just starting to distribute in Kenya, Mozambique. And we've got 3 social impact campaigns running through some of the margins we've made on that as well. Just in terms of tech, I always say, for what it's worth, I'm a bit of an AI skeptic. I don't actually think it would help us too much right now, but everything we do is tech driven. So on the sales or the medicine distribution side, including sales, distribution, etc., we have tech to support that. We have a big warehouse, 20,000 square foot. We're doing warehouse management, distribution management, sales and marketing. We took the tech off the shelf for that, industry standard, SaaS products. We then have our impact campaigns, registering people from events, collecting the public health data, etc. Fully separate, fully federated, different teams, different business units, different legal entities. So we are seeing sort of medicine distribution data, and we are getting public health data. And this is sort of our strategy for this year. I mean, we're literally Q1 goals is starting to build this. But we're taking all this data from the warehouse, the distribution, the sales, the pharmacy stock levels, all that stuff, and the public health data. And we've sort of built a big data warehouse in Google Cloud. We're automating the cleaning, putting it all in one place. And looking to use that to run better operations and really just understand needs and forecast demand. That's all we really care about. What are the gaps? What are the needs? What medicines are too expensive? What health areas are really driving inequity? Use that to drive our programming and sort of forecasts around that, avoiding waste of medicine procurement and so on. So we do think about plugging AI into this, but for right now, we're just trying to get the data in one place and use it to, drive the needs and forecasting. So just rolling forward into some of the data, and I've actually just brought some of the dashboards and stuff together today. Just thought this would be interesting. Firstly, we believe in hyper-localized healthcare. It's staggering to look at Village 1 next to Village 2. You'd think their health needs might be quite similar. They can be pretty damn opposite. Hypertension really high in Village 1. Next door, you're talking about kidney disease, for example. So you'll be surprised at even villages 5 kilometers apart, how diverse their health needs can be. We're using data and digital to drive more efficient healthcare models. If we're going to do diabetes screening, do it in house 1, house 20, house 50, versus just a blanket, optimizing the limited health resources. And that's sort of our angle on digital and tech. I would also add, I really like Reach's work, Reach Digital Health's work. we've only got tech used by health workers and our field team. So we've sort of tried to work directly with communities, but we've also really focused on online to offline models. We have an app used by health workers. We have an app used by a field team that helps their community get connected. So yeah, just took some data. It was in PowerPoint, sorry. Looking at hypertension screening needs. We'll come back to some of the outcomes later. Philippines, you take a sort of similar community, about 30% of people need hypertension screening. Indonesia, you look at the risk factors, 50%. Cambodia, 71%. India, 64%. So straight away, by looking at hypertension risk factors, those percentages map into households. We know who to do education or blood pressure screenings with. This is one of my probably favorite case studies from Kenya. This was last year. Kenya has a target of 5%, less than 5% of the population being malnourished. So we were working in one county in Kenya, and overall 3% of the population was malnourished. That's good. That's below the target, right, of 5%. When you actually break it down, I've just masked the subregions on the left. Some communities were 0.8% malnourished, some were 0.2% malnourished. One village was 30% malnourished. Of that percentage, 85% was females below 15. So we work with the county health leadership. 3% is good. It's below the 5% target. You actually look in 2 villages, focus on the adolescent females, and that's your only problem. County leadership now only focuses their nutrition programs in that sub-district, and the rest are kind of okay. And this is, again, village to village differences in some of that health data. Mental health, we've just started our first mental health program in India, looking specifically at adolescent mental health. A lot of that was driven by, upfront data collection. If we look at Philippines and Indonesia, you'll see, nearly everybody in excellent, good, or average mental health. Look at Cambodia, pretty much everybody in average, somewhat poor, or poor in terms of self-reported mental health symptoms. So yeah, really, again, looking at data, country-specific, how we design our programming, country by country, really trying to focus. The India side was interesting because if you stratify that by age, huge adolescent mental health issue problems, younger females, exam stress from parents. You actually look at it by age, and we just started this year adolescent mental health program for that reason. Talked a bit about medicines earlier. This one shocked me, actually. We were looking to do maternal health commodity distribution in Eastern and Southern Africa. So this is data from Kenya, Tanzania, and somewhere else, I forget. These are 12, I think, well, we've only got 8 on the list, but we did it for 12 products. These are basic MNCH products. If you're a doctor in Singapore or Bangkok, these are pretty bread and butter generic products. Oh, sorry, I'm going to be a minute over. So if you just look at oxytocin, iron folic acid, widely available, huge price variability. You go to a private channel pharmacy, you could be paying 28 cents, you could be paying 76 cents. Depends which pharmacy you go to. Could be paying $1.30, could be paying $10.75. I mean, this is the level of disparity in pharmacy to pharmacy pricing. Middle section, in the market, we couldn't find it 40% of the time. So you have that disparity and you have major stockouts. For the 2 products on the left, we couldn't find them available in any rural pharmacy, full stop. 0 availability, 0 price data. So in our East Africa growth, it's those 2 products that we couldn't find that we're launching first. So we're just registering those at the moment. They should be for sale in Q2. And really looking to launch these expensive or not even available, hard to find products. Outcomes, sorry, maybe 2 minutes over. When you do this and you track the outcomes, you see health indicators get better. So when we targeted those houses at risk of hypertension, we had, $1, $2 treatments available, 65% reduction in stage 2 hypertension within 90 days. You can have these slides after, but people are more adherent to treatment. 70% of mothers are going for their ANC visits, et cetera, et cetera. So educate the health workers, target the campaigns, have the medicines available. Lo and behold, health outcomes get better. And then, just final one, learnings. It's already been touched as well, but get the basics right. Governance, consent, common data standards genuinely keeps me up at night that all the good social innovators could be creating silos and unsustainable problems of the future. You must have a digital front door to a health system that works. I get a bit frustrated when I see fancy apps, and then also health systems without health centers, without paid doctors, medicines, screening kits. I mean, what's the point of a lovely digital front door connecting people to a health center that can't really help them? And yeah, from my personal view, from how we're using tech and soon, hopefully, AI, focus on enablement first, empower the health workers, empower the existing community members, and sort of channel shift to digital native second. Sorry for being a bit over. Thank you.
Ed, excellent. Thank you. I know you said you're an AI skeptic, although you showed a lot of AI backend technology. But I would like to move to the fire chat. There's no fire here, but it's a virtual one. We could make a virtual fire there. I would like to go back to AI actually a little bit and ask you, Rose, about what steps could be taken to ensure that AI healthcare tools prioritize the needs of the underserved communities. Also, since we just saw that from Ed, like some of the devil's in the detail on these. So just what's your take?
Hello? Oh, okay, great. So I'm going to just delve in. Obviously, we have talked about the issue on internet. We have talked about those factors, and I'm going to highlight that it's very important, especially when in Africa, to just engage our communities as we're building these AI solutions. And engaging them means educating them. Just to paint a picture, some of our communities still believe in traditional medicine, and even just bringing this AI concept to them, and actually just impacting even the modern medicine is a challenge. So imagine now bringing the AI systems that they don't even use and believe in. So there's that, educating them, and just not educating them in the context of bringing them into a conference they won't attend. So that is also reaching to them in their environment. So that is mostly, an example, you can reach to them through their church communities, engage these communities where they are highly represented. And also, I think another thing would be, due to the challenges we have with internet, developing tools that are our AI models that would function with low bandwidth. I think Debbie mentioned during the COVID time, they used USSD. And I know there's an organization called Jacaranda Health in Kenya that uses USSD as a form of helping mothers with maternal health education, and also just supporting them with their institutions. So that's maybe some ways that I can suggest. And there's very many more, like just, again, the diverse data sets that we talk about, they should also be included in this AI solutions.
Thank you, Rose. I think I would like to add voice to that as well. So when you actually, not even USSD works, sometimes Ethiopia, for instance, is one of the countries where, although this is getting rapidly better, where you have to use like these IVR models and just go through voice, and that's still an option. And but yeah, I think that's a great point. We need to have different technologies to make sure we don't create that gap. And yeah, excellent. Thank you. I will come back to you later, but I want to ask Osama, going back to your presentation, Osama, India is the largest country in the world now by population. And with many sort of living in rural areas, what kind of interventions can be made to comprehensively impact the health status of these people?
So, since we are talking about AI-driven and AI-centric and data-centric, and of course, people concerned, if you're talking about health, I would say that there are two lines of action that must be taken. One is that all the frontline health workers should be comprehensively trained in digital tools and digital handling and data collection, because they are the people who are connected with the people, 2.42 million people to 1.4 billion people, they have about 500 people ratio. So they must be, because they are at the front line with connecting with the people. So that's number one. Number two is public infrastructure related to health. I mean, in general also, but in this case, related to health, must be properly, enabled with digital infrastructure, which can create a better information system. Information system may not be, like you immediately start trying doing operation offline, or I mean from distance or something, using that tool, which is curative. So mostly from the preventive medicine perspective, preventive health and information based, we can create, which is basically community health centers, public health centers, and sub centers. These are the three level which is closest to the people. Those three must be done. And the third, proper data collection policy, data privacy, and people's consent, those kind of thing should be embedded, because most of your future health services are going to be based on the information of the people, and you have been collecting, but the point is now you are going to collect more from the perspective of driving algorithm and driving decision making tools. Then you need to have that consent in place. At the moment, most of the frontline health workers have been given or have the mobile phone or the smartphone to collect the data and feed the data and put their responsibility. But I don't think they are so well twined to work with different kind of databases and things like that, right? And of course, the larger good is that we create literacy in a proper manner, and we do not create literacy from the perspective of only being an individual user, but more like a public user and through the public infrastructure. That's what I would say.
Osama, also thank you for mentioning the consent piece. This is actually one of the topics we have is the enabling environment. And we need to set these guardrails, and yeah, thanks for mentioning, because I have seen so many programs where you have been quick to do something, but just
give me one
on that second, yeah,
second,
would like to hear.
30 second thing I want to add on the consent, because consent is very important in a country like India, where people live on the doles of the government, on welfareism. What happens is that every 6 months or every 1 year, you come with a new scheme saying that this is for you. And they are ready to give all kind of data to get that 5 kg of rice or 10 kg of something, or sugar or whatever, the ration, anything. We are ready to give any data. So the value of consent to be understood by the people goes back to the person who is collecting the data and not the person who is actually giving the consent. We need to really consent is loaded one, in the sense that we are taking this data and this is how we will be used, and it has its own literacy challenges.
Absolutely.
And that's a deeper one in a environment where you are going to use the data for larger purpose.
No, and it was a small part when it came out at GDPR, which has been often copied, to say like, it's not just to have consent. You have to make sure that those who give consent actually understand what they're consenting to, which is a very important part. So thanks for mentioning that. Debbie, I would like to move a little bit to like direct client interaction. So, which is something that you did with Reach, which was like fascinating, how you actually directly reach via SMS or WhatsApp citizens and healthcare workers using these simple communication methods. But you mentioned that only 70% of ownership of mobile phones in sub-Saharan Africa. And I think that was they were not even smartphones. So how are we reaching the people who we need to help? So what other methods could we do, and where are we going? And I know this might be a now problem, and this is rapidly changing, but what's your take?
Yeah, I think it is rapidly changing, and I think you guys actually touched a little bit on voice, for example. So I think voice is incredibly important because of literacy. I also think it's important to understand things like people might have access to a mobile phone, but not necessarily own a mobile phone. So how are you making sure that you design your services for those who have access, not those who own necessarily? And so that's one of the really important things that we take into account to try and reach as many people as possible. And then I think the third is, you do have to have those those non-digital ways of engaging and doing health promotion. You have to, if you're not doing it yourself, you need to be working within a system that can, because otherwise you are going to be leaving people behind. And just one little point on the AI and how it's affecting, it could potentially increase inequality. I think, we build these WhatsApp services like Mom Connect, where you talk directly to citizens about MNCH. And we have spent a long time making it cost effective. So at the moment, it costs about 20 US cents per person per year to maintain, which is very cost effective when you're at scale. But if we wanted to build this using the same service, using a large language model and all the fancy things that we as technologists want to use because we love shiny new objects, we would be increasing the cost by $10. So it would move from 20 US cents to $10.20 US cents to be able to use one of these large language models because of the cost of compute. I have to admit, I have not done this calculation on DeepSeek. This is a calculation done on ChatGPT, but maybe it's half of the cost. It's still an enormous cost to add AI to your services. And so one of the ways we think about that is like, if you're using these large language models, which is so much fun, you use it like a Swiss Army knife, and you can do lots of experimentation and you can try all new things. But often when you're building a service that's scalable, you actually just need a screwdriver. You just need that one little thing, that one maybe small language model, or even, God forbid, like non-generative AI. And that's actually where you can sometimes have the biggest impact.
Like a RAG model and other things that are there. Yeah.
Exactly.
So where you just really concentrate on the source of data. And thanks for mentioning DeepSeek. We had, when we prepared the slides for the very first session, that came out of nowhere, and we had this thing that everything's controlled by these three companies. And whereas all of a sudden, whoa, something just happened. So, which is very, very encouraging to use it with, because there were a lot of sessions also with climate, which is not part of this session here, because we're like, wow, okay, we have like difficulties for access and so forth, but AI also in itself generates a huge footprint. And who knows, there's maybe something in here now, exciting times. As I said, it changes all the time. Ed, you were talking about the difficulties to reach like rural community areas and how digital use can help. Can you maybe tell us a little bit what are the learnings from sort of digital programs there? You had very detailed data on like even from one village to the other and so forth, so which I found fascinating. And how can we overcome these key challenges when you were sort of operate in that environment?
Yeah, sure. Thank you. Sorry. Thank you for the question. So yeah, even just like Genesis of Reach 52, been in Southeast Asia for coming up to 10 years. First version of our app, we were a health tech play. We had a sort of kiosk that could go on schools or shops or churches or places of worship, this kind of thing. And people could get educational content, speak to a doctor for free, and potentially order a discounted medicine. So sort of like a shared telehealth model, plus ordering affordable products, and those products could be shipped back to the school. None of that worked. Pushed this for 2 years, got our first funding, got pharma companies to agree to provide heavily discounted products. We launched in the Philippines. I moved to Manila. I lived there for 1.5 years. Absolute failure. The only thing that I think the tablet got used for was like kids playing with it and breaking it. But people don't want to consume health services that way. People don't read the consent. they click, it's not like a natural sort of pathway. So yeah, it was only just before COVID, really, like mid 2019, that we flipped that app to be used by people in the community. And I always said, if people aren't going to use the tech directly, we have to empower locally, embedded people to use the tech to sort of provide that interface, at least to start. So yes, that's how we came to go more and more rural. If you actually are in cities, people often don't, go to a health worker. They have a pharmacy, they have a doctor. So we were able to go more rural and, in a way, be less relevant to the urban areas. But then, yeah, even more problems started when we did that, right? Because, things like consent, I'm obsessed by consent, like 2020, 2021, like absolutely obsessed by legitimate consent. Because, yeah, as was rightly said earlier, if somebody's, to some extent, desperate for health services, they'll just say yes. And that didn't feel like legitimate consent. If we do build this big data asset, not that we really want to monetize data at all, we want to use data to drive programming. But if we do, I mean, it's shaky foundations, right? So we had to, we started using health workers, online to offline models. Secondly, we had to completely reimagine consent. We did do quite a lot of, A/B split tests around this, even using cartoons, videos. How do we do it properly? Huge differences between age. We did notice that people in their 20s, short one-page consent forms kind of make most sense. If doing a test, it worked. If you were working with older people, we were doing like stories and comic book strips, this kind of thing to like sort of bring consent to life and contextualize it in more relevant terms. And we still use all that. So if we're actually getting consent, we'd actually talk more about, do you want some bullet points? Do you want the full spiel? Or you can watch this little cartoon on my video, on my phone, and this kind of thing. And we find that really works, and there is big age differences between that. I think, yeah, the other just sort of biggest learning is just the sort of whole system approach. I mean, originally we started with tech, collecting data, and this is again post-COVID, just sitting there looking at the data and being like shit, like there's only so much you can do with tech. And you need to actually say, well, what about paying the health workers? What about buying screening kits? What about the fact medicines are $10 where we can now manufacture it for like 50 cents and, sell it for $1 and, make a margin for distribution in the middle. So yeah, for us, it was like sort of, tech to online to offline, rethinking consent. But then as you look at the data, you really need to think about the whole system, because otherwise you do just build a digital front door to a health system that can't help people as you go more rural.
Thanks, Ed, and thanks for, again, mentioning the community health workers, what Osama also mentioned before. I implemented EMR system in clinics for a long time, and it is nothing, it doesn't even touch what these community workers actually do, and these are absolute heroes. And if you work with the community health workers, that's where you sort of reach that last mile. So like, thanks for mentioning that. Rose, I would like to go back and talk a little bit what we just heard about DeepSeek and AI and affordability, because there might be a little change here, but let's hope for it. But at the moment, many of these AI-based healthcare tools, they're very expensive to implement. And how can we drive innovation that focuses on affordability while maintaining the effectiveness in low middle-income countries?
Yes, I would love also the panelists to also join me in maybe giving more context on the healthcare, but I also, I feel like open source is going to be a game changer, to be honest. It's something we're very excited about as developers in Africa, because we have been using open source, we have been using different Hugging Face, the likes that we have access to, and we have been able to develop language models, developed our own LLM models to be able to incorporate in chatbots that are assisting in our different communities. So I'm very excited to see maybe an invention like, a DeepSeek that is coming up, and see how it will be able to reduce these kind of expenses and enable accessibility. And another thing I would like also to incorporate in there is like the partnership with local innovators, and even mention again what we do with Zindi. We have data scientists who are still looking for opportunities, but we are able to engage them in developing AI solutions for African data sets. And yes, it's as much as it's not the pay grade that they would want, it's giving them accessibility to the skill set, and it's also bridging the gap, enabling the equity environment for them to develop solutions for their community, for themselves, and have an impact. And yeah, I think this collaboration and even the support by the government and other institutions is going to enable us to support our communities, the low income communities, with these AI solutions, better AI solutions.
And what Rose just mentioned, I don't know if you know that DeepSeek is actually an open source sort of development, which is what makes it so exciting for our community. Because as Rose, as you said, like we work with open source tools since ever. Digital public goods like DHIS2, OpenMRS, which we might use in our area a lot, and then but it's for a reason. It has to do with the cost of the implementation, also so the community has been built around. And yeah, I share that excitement. That's and hopefully we can fit it into the guardrails that we're coming up with, the enabling environment, to go back to that as well, for where we set for the open source community, where we said, okay, you have all these innovations coming up in my country. And I always mention that moratorium on digital tools back in Uganda in 2011. We said you have all these different digital interventions, but then we need to think about interoperability. We need to think about strategy in our country. And this is where we came together in the community and built these guidelines on FIRE, where we work together. So now these open source tools can actually sort of exchange data easier. So let's see what happens with AI and yeah. So but thanks for mentioning the open source tools.
One thing though. I'm also excited. I'm not anti open source at all. In fact, I've seen so many amazing implementations come from open source. I think, though, much like I said, for every opportunity, there's another side to it, and that's the challenges. And I think one thing we have to really recognize is, for open source to be implemented well within a country, you have to have deep technical skills. You can't just click a button, put in a credit card, and be able to use something, which is what SaaS allows you to do. And so what we have to be careful about is that with the brain drain that you were mentioning, Rose, we're losing technical skills on the continent, and we'll have fewer and fewer people who are able to actually implement open source solutions. So we need to be careful that we're not forgetting about the need to also improve technical skills on the continent. Otherwise, we're not going to have anyone who can implement any of the open source technology.
Very good point.
Yeah, I'm also in the belief that as we develop this AI solution, now the issue is, we want to develop them, but they're very expensive, and then you find that we don't have institutions or companies that can support that. So maybe with the hope and the belief that us being able to develop these AI solutions now with open source will have like an impact in our continent to retain this talent, and more investments coming to support these solutions. So it's a hope. Let's see how it goes. Yeah.
Fascinating. As yet, open source is not always cheaper. It depends.
Often more expensive.
Osama, I would like to ask you, I believe you have more than 2 million women as frontline health workers in the programs you mentioned. Is there a way that they can play a more leading role in digital enablement, including the role of data, and help governments to solve preventative health issues?
Yeah, can I also comment on this open source?
No.
Yeah, I have never been able to understand. I mean, it's very fancy and all that open source sounds, to be very frank. And but internet is open source. The entire server farm of internet is on Linux, but internet is only controlled by 5 companies, right? And they are not controlled technologically, they're controlled behaviorally. I said this in the morning also, right? So, Android is open source, right? Android is open source, yeah. But I mean, Google, Gmail was open source in a sense that it was free also and it was open also, right? Now, can we ask how did Google develop Gemini without data? Must have appropriated all the data that was created on Gmail. Altman is already blamed for, bypassing all the copyright laws to have all the content collected from all over and then created this open AI. Open AI is the name, and then the name is Open AI, but you are talking about their $1 trillion loss because of DeepSeek. I mean, this dichotomical discussion, it's very. On the other hand, we have been given by Microsoft all the software free of cost to be used by the communities forever. Yeah, we don't pay anything for software. I just yesterday got a Zoom license for free for communities. Zoom is a proprietary company, but they are giving it to you to use it. You can always say that now, this company may work like a CCTV camera to you because they are collecting all the data because all the videos are going on the server. I mean, so this is I am not saying, I'm just saying that open and open source doesn't mean that you are not losing your identity, your data is not being theft, or you are not being controlled by your likes and dislikes and your behavioral is not, because the game has changed from, all the AI doesn't run without GPUs. Who controls GPUs? Now America has said that I don't want to give to GPUs to the China because China has developed, better AI. So, so it's a very, at the end of it, there is always this kind of control mechanism that is there, even if you call it open AI or something like that. I just want to say that.
No, and I remember if a product is free, it means you are the product.
Then you are the product.
So we all know that.
Then you are the product. Yeah, exactly. So, but coming back to, I know I will have to repeat, but what I'm saying is that in a country like India, and health as it is getting into the next phase of dependency on health. Health will be dependent on information. So the trust is very important. What application is going to be running and who is going to run is very important. And India has an advantage in a way that they have a already physical human cadre spread all over rural India and all over the villages. All they need to figure out is that how technology can embed in such a way that the trustworthy data and information knowledge is spread across them, so that they can work both ways, collecting data also, disseminating information which can prevent health hazards also, or health issues also, so that you can have a better and that's what the role of these health workers are. They are not doctors, they are health information providers and health information seekers. So the role of information, role of knowledge through digital infrastructure is going to play a huge role. And I would say that AI is going to play a very serious good role if you are based on a very good data, very good consent-oriented data, and then you are devising an automated system to give you advices and others. In any case, health is dependent on 85% on preventive health issues, which is dependent on information and advices.
It's just, these numbers are always fascinating from India when I hear 2 million from 2.4. So, Debbie, I would. Yeah, that leads very well into the next question. Let's talk about women. Debbie, you were talking about inequity, and let's talk a little bit about to address sort of gender inequality. And we had a little example before when we walked down the staircase. These numbers that always come out where you say like we have like X% of cell phone coverage, and they say 70% of a country. And what does that actually mean if you drill down into male, female, and then who actually has a smartphone and who has what we sometimes call a dumb phone, and what difference does that make for digital health? So
Yeah, I think Ed actually did a really good job of showing how aggregate data can hide some very important lessons. And I think it's very important to understand that women generally have much lower access to mobile technology, or at least the technology that they have is likely not to be as sophisticated as the technology that men have access to. And so when we think about our engagements, we have to think about how we might have to be getting to a woman, for example, via a gatekeeper. So we may be doing a maternal health program, but we might be speaking to the head of the household, who's a man, to help him to understand how he needs to allow his wife to be able to access services. And so it's very important to think about the cultural context, but also the digital divide from a gender perspective when you're designing your services. I think the other thing, though, on the other side of things, one of the strange things that we're finding, or what people might see as strange, is that a lot of our services actually have more women on them than men. Even though the access might be lower, we end up with the services having more women. And I think a lot of that is to do with how women feel about healthcare, access to healthcare, health-seeking behaviors. And so, again, the data sometimes hides the truth of what the experience is. We've found in South Africa, 78% of those who are reliant on public health infrastructure do not live with the father of their child. So there is a huge problem with fathers not being involved in the care of children. And so we're actually strangely really struggling to get fathers onto the platform so that we can have a bigger impact in the child's life. So sometimes, you know, the what you experience in real life is different to some of these aggregate data sets, and it's important to really look at that data, understand it, and design your interventions around that.
You have to think out of the box. There is a few things that who would think about that. You have to involve the fathers, and yeah, so it's that's fascinating. Yeah, as I said, like the data itself is sometimes misleading, and you just don't reach the one you want to reach. Yeah, but when back at years back when I worked for International Planned Parenthood, we always had the problem that sometimes we had, like, in the workshops, 95% women, one man. It's just not interested in this. It's a real challenge, yeah. Ed, I want to ask you, you mentioned the private sector a little bit, and and how your work's become a key topic in global agenda. How do you best see the private sector contribution in this domain? Because we were talking a lot about public, and what do you foresee? Sort of, what are the main challenges?
Yeah, thank you. Firstly, just echoing Debbie's point genuinely. I didn't say in my presentation, but yeah, about 500,000 screenings a month. We do 90% plus female. In our
Incredible.
events, we actually have the exact same problem. I was in India last week, and we've had to start doing health events at like mosques and other places of worship just because we do not pick up men, full stop. Like, most of our events is 99.something% female attendees for sure. Yeah, private sector. Yeah, we do a lot with private sector. We are a company. I think, you know, it's almost linking to the open source debate in a way. There's like a sort of middle way. You know, there's not like full profiteering and there's not fully open source. I think there's also like not full NGO, but there's not fully profiteering. We're trying to be a sort of middle way business. We are a company. We want to reinvest, you know, our profits into the mission. So we're a sort of non-profit business mindset, if that makes sense. Thinking about, yeah, even linking to the open source. There's two sides to private sector in my mind. One is building the platform, the channel, pharmacies, tech, etc. Two is, for us, the products we put through it. You know, how do we engage private sector suppliers on the open source, you know, and the tech? You know, clearly, the tech companies clearly have to play a role. Governments aren't going to create LLMs, rightly or wrongly, right? Governments aren't going to have super sophisticated cloud infrastructure, rightly or wrongly. But, you know, even when I was prior to Reach 52, I worked in strategy for the Department of Health in the UK, and we got so much proprietary vendor lock-in, you know, As soon as you work with a proprietary system, we've set up this whole patient access to their health record, integrating the data from the hospitals, the ambulance, the pharmacies, etc. Use this integration software. As soon as we got it working, the vendor jacked their prices up so much, like 10x increase. Government couldn't pay, we shut the entire thing down. So I think if we're talking about private sector in tech, I think it's everyone can give away. We get super cheap Microsoft stuff as well for all of our work, like $2 a month they charge us. But for how long, I don't know. That's the kind of example of it. So I think for private sector in the AI, tech, data, hosting space, if you do social impact, you should publish a 10-year plan, I think. Even now, one of our proprietary databases for one of the apps we've built, they're turning it off in September this year. We've been building on this. It's MongoDB, one of the biggest database providers in the world. If anyone's using Realm in the room, they're turning it off in September. We've built an entire stack off that, and it's multi-billion-dollar database provider, and they've given us 9 months. And if you rip out the database, you've got to rebuild the whole thing. So now half of our development roadmap this year is rebuilding an app that we've been using for 5 years, etc. Private sector engagement. I am often sitting on these sort of panels as like the pharma guy. I'm really anti-pharma in general, for what it's worth. I think they do a lot of harm and so on. I'm not like pro big pharma companies. I wish there was actually more. The reality is private sector don't care enough about emerging markets to do something. They don't really care. It's too much of a pain. The regulatory landscape is too difficult. There's too much risk of leakage of affordable medicines in Kenya getting back into Europe. So in a way, more private sector engagement is good, in my view. And most people think that, they're sort of working with us to do something dodgy. The reality is they don't really want to work with us. We're like dragging them to try and do some social good a lot of the time, versus like them trying to exploit poor people, this kind of thing. So yeah, private sector engagement, my view is there should be more of it. And to do that, it has to be an easier pathway, regulatory harmony, actually just making it kind of easier to do some social good, e.g. sell a heavily discounted medicine is in the interests of patient, consumers, communities, out-of-pocket health expenditure, etc. But the reality is it's 1% of what it could be, because it's generally just seen as too hard.
Well, I give you a bit of a challenge. There was this years back, Gates Foundation got sort of private sector together with some organizations.
Yeah.
And there was a passionate speech from someone who used to be at Facebook and then at Apple, and said like, we would really love to do a lot more in low middle income countries. And everyone looks at us and think we have the solutions. We don't know. We just don't know the market. We need your help. So and I started like, wow, if that's the case, how can we bridge that? Yeah. And I always found it fascinating, but because the other side of the coin was when I look at reach at the time, when we did COVID, why did you manage to reach so many in such a quarter? You had the collaboration with the WHO and the local Ministry of Health. So there was that partnership.
And also with Meta.
Yeah.
So
Meta was amazing at the time.
So I think there was huge groundswell from tech companies to address the problem. Again, I think because it affected everybody and not just the people on the continent, but in the end, it did work for us. So
yeah, the free credits were really useful at the time, and I wish that would have continued. That was fascinating. I want to give a big applause to our panels, because I would like to open it up, and I'm aware that we have 15 minutes between us and lunch. So I would like to open this up for questions on the from the audience. And so if you could just say maybe your name and what organization you're from, and go ahead.
I'm Paul Macharia from Nairobi, Kenya. I'm at the University of Nairobi and Kenyatta National Hospital. I have a question, 2 questions, short ones. I couldn't agree more with Debbie about the 2 sides of the coin. And my question is, how do we purposefully work towards harnessing the potential of AI, applying the concept of build and they will come? Because if we don't build anything because of the divide, then we are missing out. The other question is, what could be the potential role of academia in capacity building the low and middle income countries to just live up to the expectations of harnessing AI in healthcare? Thank you.
Thank you so much, Debbie. So, and I think you have these Microsoft centers as well, talking about Microsoft, to bring academia into in Kenya, which is fascinating. So, Debbie.
You said the build and it'll come. And the way that we actually think about it is build, adapt, or adopt. There is an enormous amount of money being spent on AI, not in low and middle income countries. I think my least favorite South African in the world said that if you don't spend $1 billion, you're not even at the table. And unfortunately, he's right. So I think what we have to do is we have to look very carefully where are we going to adopt things that people have already built and it's so-called stand on the shoulders of giants, because I think that there really is opportunity to use what other people have built and then take it to the next level and bring it to people who have never had access to it before. Where are we going to adapt something to be more contextually relevant? So for example, how can we use language data that we can collect to make a large language model more appropriate for South Africa? And then where can we build? Where we can build is a small section, but it's a very important one. And that's where we have the data that nobody else has. And we think about where we have the data where nobody else has, that's where we need to invest in building. So I think it's not just about building, it is about those three things, and taking quite a pragmatic approach to AI. That would be my answer to your question. And I think the role of academia, I don't know if Rose has anything to add on this. I think that it's very important for academia to be working towards capacity building. But what I would say as well is that there are often very big gulfs between the way that academia operates and the way that implementers operate. And that can cause massive friction. And so we have to think very carefully, how are we going to step between these two worlds and make it work for both of us? Because otherwise I've found that the friction can just stop people from taking advantage of the fact that there is actually so much value in collaborating with academia.
Yeah, I think on that aspect, we work with deep learning in Daba, and we have a lot of researchers that come in to contribute to AI solutions, writing the papers that we usually showcase in ICLR and the likes conferences. And I feel like capacity building is important in the aspect of just enabling these researchers to see in the aspect we can be able to collaborate with the private sectors, the government institutions, and even communicating within these conferences. We usually invite the government in order for them to be able to support the initiative of academia in building research labs, especially I know Strathmore has a research lab similarly to USIU, and all of them support this innovation and build the students' skills and knowledge on AI. And just coming into these organizations like Deep Learning in Durban now gives us the exposure, and we're able to see how these two can collaborate. So I don't know the right path in which the private sector comes with academia in building the solutions, but I know it has an impact, because these same solutions that we develop papers on, they're the same ones that are going to be used to impact the different solutions that the private sector also develops their AI products on. So I know there's a collaboration, and you should definitely check out what Indaba does and how the published papers go to result into AI products being developed.
Thank you, Rose.
Yeah, my name is Sarni. I'm from Myanmar. I'm a deputy director for a NGO called Community Partners International. So my question is for Mr. Edward. In a conflict country like Myanmar, the Reach 52 business model might not work. So in that case, like where the clinic, they doesn't even have a clean water. So in that kind of context, what kind of business model would work in that kind of area? So that would be my question. Thank you.
That's a hard answer. Firstly, yeah, just on academia, just I want to say something on that just quickly. We have tried to work with academia a lot of times, and my joke on it is that academia makes decisions in the time it takes us to go out of business. So the pace of making decisions has to speed up if you want to work with on-the-ground innovators, I think. And separately, I agree, making content bite-size. We tried to work with academia, doing like an insulin program, 300 slides to educate a rural doctor. You've got like 5 minutes max, 4 slides, 5 slides. They were trying to use this 300-slide deck. So yeah, pace of change and also bite-sizedness of content is probably the translation. Myanmar, it won't be on our website. We're not allowed to formally talk about it, but happy to chat after. We do a lot in Myanmar, funded by big donor agencies. I don't know if you've come across our work in the rural stuff that we're not allowed to talk about officially. But yeah, we do run a lot of rural services there. Obviously vaccines and stuff, by the looks of it,
But specific for the conflict
Yeah, so
situation,
the conflict
it's a
affected
tricky
regions. Yes,
one.
we do work. We do this work, right? It's funded by UN agencies. The way that we're thinking about it is you have to sort of arbitrage. So we are setting up a foundation. Actually, we're doing it in the US, 501c3. We want a percentage of from our medicine sales. We fund local programs, but at a global level, as we get profitability, we want to put money in our foundation to fund things that just don't have a business model. So I think you can think about arbitrage across a business model that sort of subsidizes something. And a lot of it is just, for me at least, it's taking a long-term view. I'm actually really supportive of our project in Myanmar. Over time, conflict will reduce over time. I remember when I started Reach 52, it was one of our primary markets to try and launch in, going back and forth to Yangon. It was the next Thailand, right? 5-6 years ago, emerging, loads of Singapore money going in there, malls popping up. I'm bullish on the future. So you also just have to take a long-term view, which is actually something startups and VC-backed organizations think about, large language models, burning billions of dollars, losing billions of dollars because you will make money in 10, 20, 30 years. And that's how I think, organizations have to think about it, donor money, sort of arbitrage business models. And, we're not really allowed to do it in global health because we sort of focus on 1 to 3 year grants, 5 years, maybe if you're lucky. But if you start taking 10-year horizons, like sort of private sector players, you can build a completely different business case in your head around how to invest. And that's kind of what we're doing.
Thanks, Ed.
So Reach 52, Reach Digital Health. In my world, that's a part of the private sector. So your comments about the private sector, I don't somewhat agree because you're part of that continuum. However, having said that, how are you regulated where you work? Thanks.
We're somewhere in between in that we are an NGO. So Reach Digital Health is an NGO. But we do also have a sort of hybrid business model in that we spun out a for-profit social impact business, which we own the shares of. So I think we do have some similarities there as well. In terms of regulation, the interesting thing is there are some countries where we're extremely regulated, and there are some countries where we're not regulated at all, and where we regulate ourselves. And so that's a choice that we've made as an organization, is where there is no regulation or where there is poor regulation, we actually adopt gold standards. So for example, GDPR, in countries where things like that don't exist, we adopt that anyway, because we believe that that's the responsible way to deliver our services. So I think it's not so much about how are you regulated by external forces, but also as an NGO, how are you regulating yourself?
Yeah, firstly, well, yeah, as per my sort of comment before, yeah, I'm not like actually super supportive in a way of, big private sector entities. The way we came to be, I started off more as a non-profit, Reach 52. But when it comes to looking at the health problems, a lot of people are paying out of pocket for medicines, and out of pocket medicines are bought through private pharmacies, right? So we just saw the problem of people are paying too much and they're going to private sector, channel pharmacies, clinics, and how do we make that lower? Non-profits generally can't trade. This is why I talk about sort of like a new type of entity. If you want to sell a medicine in the Philippines, you have to be a business. If you want to sell a medicine in India, you have to be a business. You can't be an NGO that has revenue. NGOs can take grants, and grants, you know. It's the only revenue you're allowed to accept. So if you want to solve a social problem, which is high out-of-pocket health expenditures through private pharmacies, which is where, depending on the country, 40 to 90% of healthcare is consumed, you kind of have to be a business. The way that we try and the way we regulate ourselves is everything has to align to UHC. If we're launching a product, it has to be more affordable. It can't be more expensive. Government has to approve it. It's like the baseline. So it's aligning to UHC, SDG 3, has to be cheaper. Government has to say yes. And then, yeah, as Debbie says, follow regulation in the country to the letter. And in many countries, we don't have data regulation, data privacy laws and stuff, and then we adopt GDPR. So yeah, and then it's way harder. It's way harder to try and self-regulate yourself. So yeah, I much prefer stringent regulations. Tell us where you want us to host the data. Tell us what format you want it in. Send a copy to the government. This stuff like makes life 10 times easier. But in the absence of that, adopt GDPR.
Thanks, Ed. And I just remember like a few weeks ago when the AI community came to say like we need to get regulated. They come themselves to like please regulate us.
Yeah.
But
that's a very valid point.
Yeah. Annette, you're.
Hi, I'm Annette Brown. I'm really glad that you talked about consent because that was the first question that came to my mind, Edward, when you were talking about the amount of data and the level of disaggregation that you have. Easy question. The tools that you've developed for gaining consent sound really fabulous. Are those things that you share?
No. I'm actually just like reflecting because we've also worked a bit with Turn.io when Facebook was, investing more. So we actually developed these tools with Meta. We were part of Meta's accelerator. It was when Meta were getting all the bad press for doing weird stuff in America with data. So yeah, we did develop it as an open toolkit as part of like Meta's accelerator when they were getting a lot of heat for their data privacy, that political stuff. I can't remember the name of that firm that was harvesting data from them. Yeah, more than happy to share.
It was Cambridge Analytica.
Cambridge Analytica, yeah. So yeah, we did develop them with Meta, and yeah, it's all open, and we did some really interesting studies around it. So yeah, happy to share.
The last question, and then we have lunch.
Thank you. I'm Surichai Wankau. I'm from Chulalongkorn University. I am much interested in the unevenness of global actor, global agency in responding to the calling for governance of AI. So this is for Thailand, we are going to organize a UNESCO and forum on AI and ethical governance in June, end of June this year. That's the reason I asked this is about regulatory capture has become a part of the corporate world strategy. State capture has become some kind of authoritarianism in the world. Citizens are left whatever. Now, the crisis is for us in Thailand, the main theme, although this is a main theme here, but the real theme on the ground is transnational crime. With Myanmar, with at the border and under geopolitical pressure, big powers discussing. But my point here now, I would like to ask your suggestion. How should we proceed in our next engagement in this sense of agency, creating sense of agency together, using academia, whatever it is, how late it usually become, but how can we accelerate the learning along that line? I seek your advice for acceleration of our learning to collaborate along this agenda of regulatory demands.
Thank you very much. Who would like to go? Regulation, learning. There was a lot.
That is a
There was a lot.
question.
In inter-country crime. So that was, which is very, very, I did not have that on my radar, I have to admit. So who wants to have a go?
I'll try and make a comment around that. I'm in no way an expert, so this is just my inexpert opinion. So I think I'm not really sure that anyone's getting the regulatory framework correct, to be honest, when it comes to AI. And the reason for that is because AI is moving way faster than the regulation is moving. And I think that the biggest thing that regulation needs to take on, and I haven't seen it done anyway, so I don't think it's a case of being able to say, look at this example, it's done really well. But what I do think needs to be done is that regulation needs to start happening in an iterative and an agile way, because otherwise it's never ever going to keep up with the technology. And so if you are waiting for the perfect regulatory framework, by the time you publish it, the environment will be different. And so it will be useless. So it's about, and this is a very much corporate response to, or thing that people say, fail fast and break things. You've got to put regulation in quickly, but don't expect it to be perfect. Iterate and be agile around it. And that's the only way you're going to keep up with the technology.
Thank you. I think we might have to take this offline. There's a lot more behind it. And but we're at the end of time. I would like to remind those in the audience, those who are left, there were 300 people here in between. But I actually did count, it was over 35. It's a big room. People were coming on. Those who are still here, please take a moment to complete the evaluation form that is provided. If it's paper, please drop it in the evaluation box located in front of the room after the session. And for electronic submissions, you can use the provided link or the QR code. And this is the QR code. And whoever wants to talk with me about QR hacks, I'm available. Thank you very much. It was great to have you here. Thank you to the panelists. It was really fascinating. Thank you so much.